and proceed for today's program.
So, namaste to all. Respected dignitaries of Vishwa Parishad, Rachana, SharirAmrita. Today's resource person, Dr. Bini Upendran, and all the delegates present over this virtual platform. So, it's my great, immense pleasure to introduce today's guest speaker, my friend, Dr. Bini Upendran. About Madam has completed undergraduation from Government Ayurveda Medical College, Trivandrum in the year 1998. Later pursued post-graduation in Rachana Sharira from Alvas Ayurveda College, Mudabidri in the year 2011. Presently pursuing PhD from Parul Institute of Ayurveda, Gujarat. And about Madam, she is expertise in microdissection and preparation of various innovative models in the museum and adapted various innovative teaching methodology, especially in the curriculum. So it's our fortune, we are very fortunate to have you, Madam, here. And Madam having the vast teaching experience of 14 plus years. Madam has worked as assistant and associate professor in Sri Narayana Institute of Ayurveda, Kerala, and later joined Amrita School of Ayurveda and presently working as professor and head in the department of Rachana Sharira. So in this journey, Madam has published various articles and being resource person in various conferences in national as well as international platform. And today we are very fortunate to have you on this platform and listen to you, Madam. And today, Madam is going to deliver a talk on anatomy of urinary system and its applied aspect. And with this brief introduction, I invite Madam for the guest lecture. Please, Madam.
Thank you so much, sir. I extend my sincere gratitude to the God Almighty, then my gurus, and Dr. Clappana sir, Dr. Rakesh sir, and all the dignitaries over there for giving me an opportunity to present here. Welcome, my speaker. Can I start sharing my screen, sir?
Sure, Madam. Madam, minimize second screen, Madam.
Minimize the second screen.
Actually, your PPT is not completely visible. It is hiding behind the small screen.
Okay.
Now fine. It's fine.
Okay. Yeah. Thank you, sir. And my topic is anatomy of the urinary system and its applied aspects. As Rakesh sir said, the importance of anatomy in clinical practice. Actually, if you know only the normal anatomy of an organ, you can know the abnormal things. That is a clinical anatomy. So clinical anatomy is essential for a clinical practice, and main importance of the urinary system is most of the about 5 to 10 million people die due to renal diseases. And now let me go directly to the subject, and the complications is due to the lifestyle disorders. That is, the common lifestyle disorders are diabetes, obesity, and we have already learned in Ayurveda, Meda Vahasrodhas and its relation with the kidney. Today I'm not going to explain more about the Ayurvedic portions because as you are all well aware of the Ayurvedic portions, I'm just trying to present how it can be useful. That is the urinary system, the entire urinary system can be useful for the present day practice. So the urinary system is divided into an upper urinary tract and a lower urinary tract. And the upper urinary tract includes the kidney, its blood supply, and the function of it is to produce urine. Then coming to the lower urinary tract, it includes the pelvis, the urinary bladder, and urethra. And that is the conducting system of the urine. Okay, and this is a diagram representing the position of the kidneys. So you can see this is a diaphragm, and below the diaphragm, at the region of T12 to L3 vertebra, the kidneys are located, and this is the right kidney, which is located below. The left kidney due to the presence of, as we all know, liver, and these are the suprarenal glands. And this is the aorta that is situated in the left side. Aorta is situated on the left side, and this is the inferior vena cava. And the course of the ureter directly opening into the urinary bladder, and finally the urethra. And let us just have a brush up of what the kidneys are. I know that you are well aware of that, but still, without an introduction, I cannot go to the topic. That's why. The kidneys are a pair of excretory organs situated on the posterior abdominal wall, one on each side of the vertebral column. So in the center, on each side, behind the peritoneum. So it's a retroperitoneal organ, and they remove the waste products of metabolism and excess water and salts from the blood. So the salts, when they are removed, it maintains the normal pH of the blood. You all know that the blood is slightly alkaline, and this is the kidney, and we'll deal with the kidneys. Then location. For every organ, we should know the correct location. Only then we can identify whether there is an enlargement, whether there is some tenderness or whatever. Surface knowledge is very important. So the location, not the surface knowledge, the location of each organ is very important. The kidneys occupy the epigastric, as we all know, epigastric, hypochondriac, the right hypochondriac and the left hypochondriac, and the epigastric, lumbar, and umbilical region. Vertically, they extend from the upper border of the T12 vertebra to the center of the body of the third lumbar vertebra. We are all aware of that. The right kidney is slightly lower than the left due to the presence of liver, and the left kidney is a little nearer to the median than the right. Because there is liver in the right side, the left is little more to the median side. And the shape, size, and orientation. The necessity for learning, for understanding the shape, size, and orientation is if there is an enlargement in the kidney, you need to know the measurements, and you should know the orientation. If a report comes about a detailed description about the change in orientation, you should know the exact orientation. So the kidney is about 11 centimeter. The length is 11 centimeter. The breadth is 6 centimeter, and the thickness is 3 centimeter. And the left kidney is a little longer and narrower than the right kidney. The long axis of the kidney is directed downwards and laterally, so that the upper pole are nearer to the median plane than the lower poles. The transverse axis is directed laterally and backwards. So it is almost directed towards the front, and the posterior part is directed a little backwards. And then the weight of the kidney, it is 150 to 180 gram, upper pole, lower pole. So this is the upper pole, this is a lower pole, and this is a middle pole. And it is made up of an outer cortex and inner medulla, which is well demarcated. As you have all noticed in the scan reports, they might write the corticomedullary differentiation is well maintained, likewise. So it is well demarcated in a normal kidney. And in the cortical region, there are about 13 lakhs of glomeruli per kidney. So glomeruli, we will study the glomeruli in the next slides. Then the cortex is predominantly present, glomeruli. That is, glomeruli is more present. The medulla consists more of the tubules. Okay. And in a cut section, this is a cut section of the cortex, medulla, and columns of Bertini. These are the columns of Bertini. And the columns of Bertini are the extensions of the cortex in between the medulla. We will see in detail about that. So first, let me tell you about the external features in general as anatomy is concerned. It has 2 poles, 2 borders, and 2 surfaces. Upper pole, lower pole. The upper pole is broad and it is in close contact with the suprarenal gland above. And the lower pole is almost pointed. And this helps in identifying whether it is the right kidney or the left kidney, and even in identifying the organ. The 2 borders, medial border and lateral border, medially and laterally. The lateral border is convex and the medial border is concave. Its middle part, in the middle part, there is a depression which is called the hilum, to which the structures enter and leave the kidney. And there are two surfaces, that is, front surface is anterior and the posterior surfaces. And the hilum, I told you, there is a concave medial part and there is an opening, and the structures which enter and leave the hilum are from anterior to posterior: the renal vein, the renal artery, VA, and pelvis, VAP. So renal vein, renal artery, it is very, I think it's very easy to remember. VAP, vein, artery, and pelvis. Pelvis is a expanded upper part of the ureter. Okay, so vein, artery, and pelvis from anterior to posterior. And then coming to the relations of the kidney, we should know about what all organs are present in front and back of the kidney. Front, back, upper and lower part. And we already know that the kidneys are retroperitoneal organs and are only partly covered with peritoneum anteriorly, because liver is present in the front of the right, stomach is present in the front of the left. The relations common to kidneys are: the upper pole of each kidney is related to the corresponding. That we absolutely know that the glands above the kidney are called the suprarenal glands, and the lower pole lies about 2.5 centimeter above the iliac crest. So you can imagine, when the crest above 2.5 centimeter lies the lower pole of the kidney. So while palpation, you can understand if the kidneys are enlarged. Okay, and the medial border of the kidney is related to suprarenal gland above, the hilus, and to the ureter below, because we already learned vein, artery, and pelvis from anterior to posterior. So ureter continues downwards. And again, now I just mentioned about the anterior the relations of which are common to both kidneys. And upper pole of the kidney, suprarenal glands are present in both. The medial border is related to the suprarenal gland and the ureter below. Again, coming to the anterior relations of the right kidney, what all organs are present in the anterior aspect of the kidney? The right side, right suprarenal gland, of course, liver. Then the second part of the duodenum, as we all know that there are 4 parts of the duodenum: first part, second part, third part, and the fourth part. Okay, it is 25 centimeter long, and the second part is the descending part of the duodenum, and that is also related to the right kidney. And then coming to the hepatic flexure of colon. Hepatic flexure, it comes, the colon comes in the right side and gets takes a flexion, and that flexure is called, because liver is present there, it is called the hepatic flexure of the colon. And then comes the small intestine, coils of the small intestine. And out of these, the hepatic and intestinal surfaces are covered with peritoneum. That is liver, and the intestinal surface is covered with peritoneum. We all know that intestine, the large intestine has mesocolon and the small intestine has mesentery, and the latter as part of peritoneum. And the lateral border of the right kidney is related to the right lobe of liver and the hepatic flexure of the colon. I hope it is clear for everyone. And anti-relations of the left kidney, that is, what all things are related in front of the left kidney. We already know suprarenal gland, then the spleen, which is situated behind the stomach, then stomach, the part of the stomach, that is the pylorus, pyloric antrum. Then comes the pancreas, which is situated in the concavity of the duodenum. Then, of course, from here, the splenic vessels, it's also the blood supply of the stomach. It also supplies the stomach. So splenic vessels and splenic flexure and descending colon. That is on the left side. On the right side, it is the hepatic flexure, and the left side, the descending colon, is also related to the left kidney. Then comes the small intestine part, that is the jejunum. Out of these, the gastric, splenic surfaces are covered with peritoneum. Lateral border of the left kidney is related to the spleen and the descending colon. I hope you can understand what I'm saying. And coming to the relations of the back region, that is the posterior relations. The posterior surface of both kidney are related to the following. So diaphragm, as we all know, it is a dome-shaped almost like an umbrella. It covers the posterior, superior, and anterior surfaces. So the posterior surface is related to the diaphragm, the medial and lateral arcuate ligaments of the diaphragm, which connects the two leaflets of the diaphragm. I hope you're aware with the arcuate ligaments. And then comes to the psoas major, which is present in the posterior aspect of the lumbar vertebra downwards. Then the quadratus lumborum, that is that which forms the posterior abdominal wall. Then the transversus abdominis, which is a muscle in innermost muscle of the anterior abdominal wall. Then subcostal vessels, example, subcostal, iliohypogastric, and ilioinguinal nerve. And subcostal vessels and subcostal, iliohypogastric, and ilioinguinal nerves. And the diagrammatic representation is almost here. The posterior relation comes to the diaphragm. The 12th rib, that is a floating rib. Then comes the ligament, which holds the leaflets of the diaphragm. And here is the psoas major muscle, and here is the quadratus lumborum muscle. And these are the subcostal vessels, and the yellow color is the nerve. And a little lateral comes the transversus abdominis, which is the innermost layer of the anterior abdominal wall muscle. And this is the iliohypogastric nerve. And this is the ilioinguinal nerve. These structures are seen in the posterior aspect of the kidney. And coming to the coverings of the kidney, as we have already learned till now, not brushed up till now what the kidney is, the structure of the kidney, the dimensions of the kidney, the relations of the kidney. So I think you have an idea of where the kidney is situated in our body. Then now it comes to what all things are covering the kidney. So there are four main coverings of the kidney. The first one is the fibrous capsule. The fibrous capsule is a thin membrane which closely invests the kidney and lines the renal sinus. Normally, it can be easily stripped from the kidney, but in certain diseases, it becomes adherent and cannot be stripped. That is also a clinical significance here, which is normally removable, but in certain diseases, it cannot be removed, it becomes adherent. So that is the first lining. And the second lining is the perirenal or perinephric fat. Perirenal means the fat covering the fibrous capsule. It is a layer of adipose tissue lying outside the fibrous capsule. It is thickest at the borders of the kidney, that is the lateral border and medial border, and fills up the extra space in the renal sinus. Extra space, that is renal sinus, is a space found in the medial aspect that we learn in detail. And then coming to the renal fascia. The renal fascia encloses the kidney and adrenal gland, anchoring them to the posterior abdominal wall. So each organs in our body are kept in position by such fascia or ligaments. Okay. And coming to the pararenal fat. Pararenal fat is found outside the renal fascia. It is located outside the renal fascia, mainly posteriorly, separating the kidney from the abdominal muscle. So it separates the kidney from the abdominal muscles. We have already studied about the transversus abdominal muscle. So when it comes laterally, it is almost covered there. And the pararenal fat, Medo Vahasrodhas, I think you can correlate all those things here. So the fibrous capsule, the perirenal fat, the renal fascia, and the pararenal fat. Okay. You can understand the importance of Medo Vaha Srodho Moolam. Okay. And the functions of coverings of kidney. So we have learned about what is covering the kidney, where the kidney is situated, what is the dimension, everything. And now let us learn about the protection and support. The capsule, fat, and fascia shield the kidney from trauma. Of course, whatever first covering is, it prevents from trauma and maintain its fixed location. As we have already learned that it helps to anchor it in position. Then the second is protection and support. It keeps it in its position. Again, anchoring comes to the facial layers. Sorry, there is a spelling mistake. Anchors the kidney to the posterior wall. posterior wall, preventing excessive movement. That is, renal ptosis occurs when the kidney comes down. That is called renal ptosis. So anchoring is also a function of the coverings of the kidney. So when there is an abnormality in this covering, there are different types of symptoms also. Then infection barrier. So the fascia helps contain, that is, it retains the infection inside and prevents it from spreading into the abdominal organs. So it helps in protecting the other organs in the abdomen to get infected. So kidney as such, it stands by itself. Okay. Then coming to the radiology of the perirenal fat and surrounding perinephric fascia. And the fascia in the anterior part is called the Gerota's fascia. That is a perirenal. First, we learned about the, hope you remember the layers, fibrous capsule, perirenal fat, renal fascia, and pararenal fat. So this fascia, the fascia which is situated anteriorly is called Gerota's fascia, and that fascia when it comes in the posterior it is called circumflex fascia, and laterally these two unite to form the lateroconal fascia, and this is how it is seen in a CT. So radiographic images, here is a Gerota's fascia, it is situated anteriorly, and here is a sucker candle's fascia that is situated posteriorly, and it moves laterally to form the lateroconal fascia. Okay, and coming to the renal fascia. The fascia is a single, it's a bit complicated, that's why I'm just adding a slide for that. The fascia is a single multilaminated structure which is fused posteromedially with muscular fascia of psoas major. And how this fascia is formed is from the muscular fascia of the psoas major and the quadratus lumborum muscle. So psoas major muscle we already know is situated in the posterior aspect, and the quadratus lumborum muscle is also situated in the posterior aspect. From that muscle only this fascia rises. The fascia then extends from here, it extends laterally behind the kidney as bilaminated sheet, as a two-layered sheet which divides at variable point into thin layer which courses around the front as anterior perineal fascia or the Gerota's fascia, and thick posterior layer sucker canal's fascia that it continues anterolaterally, and the sucker canal's fascia continues anterolaterally to form the conal fascia or the posterior. So this is the from the fascia of the psoas major and quadratus lumborum. Anteriorly it forms the Gerota's fascia, sucker canal fascia posteriorly, and then they fuse together to form the lateral conal fascia. And this is the diagrammatic representation. So these are the kidneys, a transverse section. Transverse section anteriorly, this is the anterior renal fascia, and this is the posterior renal fascia. Fascia of Gerota, sucker canal, and this is a lateral conal fascia. This is the peritoneal space. Here are the muscles. Okay. Again, coming to pararenal or paranephric body. So, what is pararenal? What we learned is perirenal. So, it consists of a variable amount of fat lying outside the renal fascia. It is more abundant posteriorly and towards the lower pole of the kidney. It fills up the paravertebral gutter and forms a cushion for the bed, for the kidney, just like how we see in the stomach bed. So the cushion for the kidney is formed by the pararenal or paranephric body. It is fat. You should. There is a special note that perirenal fat is situated between the renal fascia and the kidney, serving different anatomical and functional purpose. So perirenal fat and pararenal fat is different, and you should always remember that. Okay. Then coming to the structure. Outer cortex is the renal cortex. It is granular. As we already know about the bean-shaped structure of the kidney, the outer cortex is granular. It contains a lot of nephrons. That is the starting of the nephron part is the glomerulus. And the cortex is made up of glomerulus. And coming to the renal medulla, the inner region contains cone-shaped renal pyramids. That is, when we cut the section in a coronal section, we can see a lot of renal pyramids. So renal pyramids, and they are separated by renal columns. So in between the pyramids, so these are the renal pyramids. In between there are renal columns. These renal columns are the extension of the renal cortex. Okay. Extension of the cortex. And coming to the renal sinus. What is renal sinus? It is a space that extends into the kidney from the hilus. A space extends. This is the hilus. A space extends into the kidney. Here is the renal sinus. Again, coming to the renal pyramids. So pyramid, as we already know, it is triangular. The tips, the papillae of the pyramids drain into the calyces. So the pyramids are almost like inverted, and it opens into the calyces of the kidney. We already know that there are minor and major calyx. Urine collection system. The renal pyramids are the urine collecting system. And then comes the minor calyces, which collects urine from the papillae. And then the major calyx merged by the minor calyces. Then the renal pelvis is a funnel-shaped area collecting urine from major calyx leading into the ureter. So this is a diagrammatic representation of the kidney. The outer cortex, this is the inner medulla, which consists of renal pyramids, and these are extensions called renal papillae. They open into the renal columns are anchoring renal cortex in between the renal pyramid. They open into small calyces called the minor calyx, and they open into major calyx, and then finally the major calyx open into the renal pelvis, or the starting part of the urethra. Sorry, urinary bladder, starting part of the urinary bladder. So as we already know, we already learned in school about the glomerular apparatus. Glomeruli, the functional, we already learned in school, it is a functional unit of kidneys, and it has a tuft of capillaries, efferent and afferent. So this comes to the detailed anatomical structure of how the glomerulus is. So the glomerulus is a tuft of high pressure capillaries. You should know this because there comes the significance of the function of the kidneys. Okay, a tuft of capillaries. These are the tuft of capillaries fed by an afferent. Afferent, always you know, afferent means towards. So this is an afferent arteriole, and drained by a narrow, and from here it undergoes various filtration process, and then it drains into the efferent arteriole. This fenestrated porous walls. So these are the fenestrated, means with lot of frills. Porous walls allow water and small solutes to filter out while retaining blood cells and large protein. So protein and blood cells will be retained, and the other will be filtered and moved through the efferent arteriole. Okay, so we can see that this is the Bowman's capsule. It has a matrix. The mesangial cells are the cells which helps in extra, just like phagocytes. Okay, and the epithelium and podocytes. So podocytes have a very important function. The podocytes that we'll learn in detail. Now the glomerulus is being dealt with how the podocytes function. Okay, so here is the endothelium of the glomerulus, the efferent and the afferent arteriole. Sorry, a double wall cup. So the Bowman's capsule is a double wall, that is one layer here and the other layer here. So you can see that it is a double walled cup shaped structure that encloses the glomerulus. Glomerulus means the tuft of capillaries. The inner visceral layer. So it has an inner visceral layer which contains specialized cells called podocytes. The visceral layer contains specialized cells called, you see, this is the podocytes. that form filtration slits. It forms slits to further refine the ultrafiltrate. The podocytes are very important, and you should learn more about that for learning the function and functional aspects of the glomerulus. Okay, so this is a detailed diagram. This is the glomerulus and how the podocytes are lined in the visceral layer. And this is the basement membrane. It contains capillaries. And this is the intraglomerular mesangial cells, which functions as phagocytic, which is phagocytic in functions, and it has various functions. Okay, let's deal in detail. Okay, and this is another diagrammatic representation. So RBC and albumin are filtered and absorbed here, and the rest of the solutes move taken away from the glomerulus. And this is how the molecules flow from here. In between here is a filtration slit, and this is the cell skeleton, and this is a food process of the podocytes, and the molecules flow through this filtration slit, and RBCs and albumin retain here. Okay, and coming to the renal tubule, as we all know, what a renal tubule is: PCT, loop of Henle, and DCT. So, just to refresh your memory, the proximal convoluted is the first part of the. This is a proximal convoluted tubule. It is the first part of the tubule located in the cortex, and it is lined by simple cuboidal epithelium featuring a brush border. We already know that. Hope you remember. That is microvilli is there to maximize. Villi means it increases the surface area. So what happens in what is that? Papillae-like extensions. So it's just like rugae inside the stomach, which helps to expand, and villi in the intestine, which helps to increase the surface area to maximize the reabsorption of water, glucose, and amino acids. Then, so what all things are absorbed here? The reabsorption of water, glucose, and amino acids are absorbed in the PCT, that is a proximal convoluted tubule. And then coming to the loop of Henle. So Henle's loop has a descending and an ascending limb. So a U-shaped structure. It is a U-shaped structure that descends into the medulla and ascends back to the cortex. It ascends back to the cortex, and it consists of descending limb, a descending limb, and an ascending limb. It is permeable. The descending limb is permeable to water, and the ascending limb is permeable to electrolytes like sodium and chloride. We all go for sodium test, salts, the test for salts when there are certain symptoms in patients, isn't it? So it takes place in the loop of Henle, and especially water in the descending part and the salts in the ascending part. Again, coming to the distal convoluted tubule, a shorter coil segment in the cortex, and it is found in the cortex, that performs fine tuning of electrolytes and pH under hormonal control. That is aldosterone hormone controls that. So here, the main thing which takes place is it maintains the pH of the blood. So in certain disease, you can see that there is acidosis, which causes a critical condition for the patient. Okay. Then coming to the structure of the uriniferous tubule, each kidney is composed of 1 to 3 million uriniferous tubule. Each tubule contains two parts: the exclusive part called nephron, which elaborates, that is, which drains each and every part, and unwanted, it removes the unwanted part, and whatever is essential for the body, it is taken. And nephron is a functional unit of the kidney, and it comprises of the renal corpuscle or the Malpighian corpuscle, which helps in filtration of substances from the plasma made up of glomerulus. And the Latin word is ball, the glomerulus, and a tuft of capillaries of Bowman's capsule. Again, the renal tubule. that we already studied for selective absorption. Selective absorption, that is important here, from the glomerular filtrate made up of proximal convoluted tubule, loop of Henle, and descending limb, ascending limb, distal convoluted tubule. The Henle's loop contains the descending and ascending limb, and finally into the distal convoluted tubule. Hope you can understand. And this is a Morris parallelogram. A Morris parallelogram is essential for understanding the surface anatomy of the kidney. What is the significance is? What the significance is for taking a biopsy of the kidney? This surface anatomy, Morris parallelogram, is used. So it is from intervention is from the T11 to the position is from not intervention. The position is from T11 to L3. In the right kidney lies about the upper pole of the left kidney lies about 2.5 centimeter. The right and left upper pole lies about 2.5 centimeter from in between, in front of the lower border of the 11th thoracic vertebra, and the hilum lies at about 5 centimeter away from the L1 in the left and also in the right, a little more lower part. And then coming to the lower pole. Lower pole is about approximately 7.5 centimeter from the third lumbar vertebra. Okay. And as we all know, the length and breadth, and with that, we intervene with the doctors intervene with the biopsy, FNAC test. So Morris parallelogram is essential for clinical practice. Knowledge of the Morris parallelogram. Okay, I hope you can understand what I'm saying. Okay, again coming to the applied aspects. Renal infection. So renal infection is already abscess limited to renal fascia and renal fat. We already know about the structure, that is a renal fascia, versus the perirenal fat, then renal fascia, and finally is a pararenal fat. And infection is limited to that particular area. As we already know, the functions of the coverings are to limit the infection to that particular area and prevent it from spreading to the abdominal organs. Then trauma to the kidney. So there is a blunt trauma to the back at the area of the erector spinae muscle. The kidneys might be damaged. Then renal hematoma. After trauma confined to the renal capsule, will be confined to the renal capsule and fat. That is why the coverings of the kidney are important here. Then tumors of the kidney remains within the capsule, and renal biopsy or renal surgery, Morris parallelogram, is used to approach the kidney. Again, coming to the ultrasound and CT scan, delineate the renal anatomy from hilum to perinephric area. Okay, and then the renal size reduced to less than 8 centimeter when the kidney fails permanently, and that condition is called CKD, or the chronic kidney disease. I hope all of you are aware of the term CKD. CKD means it's a chronic kidney disease condition. So here the kidney fails permanently. When it fails permanently, it reduces in size. And in early CKD, corticomedullary differentiation blurs. That is, there is no well-defined cortex and medulla, as glomerulus gets scarred, and the glomerulus is scarred in an X or in a diagram. And then the cut section also fails in progression with the chronic kidney disease. And then breaks in glomerular basement membrane. When as we also read about the podocytes, and hope you remember, and when there is a break in the basement membrane, albumin leaks out. That is, albumin and blood is stored. When that is broken, this leaks out. And cells in the urinary space, that is, urine blocks. When there are cells in the urinary space, blocks urine flow, and it leads to kidney failure. When the flow is not proper, it leads to kidney failure. And low blood pressure. When the pressure is low, it reduces the filtration. And loss of permeability of membrane lead to renal failure. So if the membrane is not permeable, you cannot absorb the salts, and the function is not salts and necessary blood and albumin, and it finally leads to renal failure. Okay. Then the minimal change disease primarily involves the flattening of the podocyte foot process. So in minimal change disease, what happens in the beginning is the podocytes becomes flattened. I told you the importance of podocytes. So definitely you should learn more about the podocytes to evaluate the prognosis of a kidney disease. Okay. The podocyte foot process in Alport syndrome caused by genetic mutations in the type 4 collagen, leading to defective and leaky GBM. Okay. And diabetic nephropathy involves thickening of the glomerular basement membrane. GBM is glomerular basement membrane. Thickening of what happens in diabetes, they say after prolonged diabetes it led to kidney failure, and there is leakage of albumin, and the kidneys are damaged. Now he's doing dialysis. The common cause is the thickening of the glomerular basement membrane, or the GBM, and loss of endothelial glycocalyx due to chronic high blood sugar. Okay, so this is a complication in diabetes, and it leads to minimal change disease, and finally chronic kidney, CKD, chronic kidney disease. Again, this is a diagrammatic representation of a perinephric hematoma. Hematoma is here, and this is a renal cell carcinoma. Here, it has increased in size, and it almost covers the whole of the posterior abdomen. And air in kidney is usually seen in emphysematous pyelonephritis, EPN. So what happens here is the bacterial infection, the bacteria invades the coverings of the kidney, and it produces gases. And these gas remains in the air, remains as air inside the kidney, inside the covering of the kidney, and that condition is called emphysematous pyelonephritis. And there is no bacteria, there is air in the kidney. It is a very dangerous situation, and it is fatal. Okay, and this is a CT of the EPN. And coming to anomalies, that is ectopic kidney. Ectopic means it does not ascend during a normal embryological development period, and the kidney will be situated almost in the iliac region only. It doesn't ascend upwards. This is an ectopic kidney, diagram of an ectopic kidney, and this is a horseshoe kidney in which the kidneys do not fuse, do not separate. It fuses anteriorly, and it is situated in the anterior aspect. So in such a case, always, sometimes it might be just, you can live with that, but you should be careful because it is situated anteriorly, so it can cause any damage. It is not completely, actually the normal kidneys will be in the posterior aspect, and it is protected. When it is anterior, it can cause direct damage because it is not covered by any bone, or it is not protected. Okay, so this is a diagrammatic representation of an horseshoe kidney where the two kidneys fuse together in its anterior aspect. Then coming to the pelvis, urethra, as the topic is the urinary system. I cannot, sir was telling kidneys okay, but then when it came to urinary system, I should continue with that. Even the kidney itself is a big topic, and I have made a very little slides regarding the urinary urethra and ureters. Okay. So the pelvis, urethra, urinary bladder, and that is the pelvis of the ureter, and the urethra, urinary bladder, ureter only. There was a spelling mistake, I'm sorry. And that is the conducting zone or the lower urinary tract. So this is the diagrammatic representation of the renal papilla opening into minor calyx, then finally into the major calyx, then the renal pelvis, and then it goes to the ureter. And from here, the ureter, it passes downwards to the urinary bladder, and from there to the urethra. So the urethra has an upper sphincter called the internal urethral sphincter, and the lower sphincter is called the external urethral sphincter. Okay. A small introduction to the ureter, a part of a pair. I know that you already know, but without saying this much, I cannot go more. A pair of narrow, thick-walled muscular tubes which convey urine from the kidney to the urinary bladder, and its dimensions, that is measurement, in an average adult is approximately 25 to 30 centimeter, that is 10 to 12 inches long. It is about 3.3 to 4 millimeter in diameter, and the path is, they begin at the renal pelvis of the kidney and descend through the abdomen along the psoas major muscle that is situated in the posterior aspect. And then the segments are, it is divided into three segments, three parts. That is, one is the abdominal part, the second is the pelvic part, distal part. Proximal is the abdominal, the distal is the pelvic part, and the next one is the intramural, that is within the bladder. These are the three segments: abdominal, pelvic, and intramural. Proximal, distal, and intramural part. Again, coming to the inner lining, that is the mucosa, it is lined with urothelium. It is transitional epithelium because it needs to expand. And then the middle layer is the muscularis, or the muscular layer, composed of smooth muscle that contract in waves, that is peristalsis, to push the urine towards the bladder. And then coming to the adventitia, it is a fibrous connective tissue containing blood vessels, the outer one. So inner, middle, and outer. Mucosa, muscularis, and the adventitia are the three layers of the ureter, and the three segments are the abdominal, pelvic, and the intramural. The dimension is about 25 to 30 centimeter, and the path is from the kidney, pelvis of the kidney, through the abdomen to the along the psoas major muscle and enters the urinary bladder. Okay. And the constrictions, as we already know, there are 5 constrictions. One at the pelvic-ureteric junction, at the brim of the, then the second at the brim of the lesser pelvis, and third one, the crossing of ureter by ductus deferens or proud ligament in males and proud ligament of uterus in females. And during its oblique, as it passes obliquely through the bladder, that is the fourth one. And the fifth one is at the opening of the lateral angle of the trigone. So there are 5 constrictions that we already learned in the anatomy of the ureter. And the anatomical importance, that is applied anatomy, clinical importance of it is, the stones get impacted in the ureter in particular points. Here is renal fascia, then the uretropelvic junction, then this is an abdominal sphincter here, and here is the iliac artery passes here, and here also stone gets impacted, and it causes severe pain from loin to groin. And then in between the the pelvis, the pelvic part, and the intramural part. So these are the 3 parts where the stones get impacted in the ureters. We know that there are 5 constrictions, and these are the 3 main parts where the stones calculi get impacted in the ureters. And then coming to the final part, that is a urinary bladder. And you all know that it is a muscular reservoir of urine which lies in the anterior part of the pelvic cavity, and the function is it acts as temporary reservoir. It collects urine from kidneys through the ureters. That is, it stores the urine and voids it out. And the capacity in healthy adults is about 300 to 600 ml of urine. The urge to urinate usually begins when the bladder reaches from 150 to 250 ml. Okay. And the structure is detrusor muscle, then the trigone, and the rugae. The detrusor is a thick muscle wall that contracts, that squeezes the urine out. And then coming to the trigone is a smooth triangular. It is a triangular area at the base of the bladder and is formed by two ureteric openings. So the trigone, in the base of the trigone only, the two ureters open. And then comes to the rugae, which are the internal folds that allow the bladder to expand as it fills. So these are the three structures in the three parts inside the urinary bladder. One is the detrusor muscle, the second is the trigone, that is a smooth triangular area, and where the ureters enter, and the third part is the rugae, that is the foldings inside the bladder which helps it to expand. And then coming to the external features. This is the external feature of urinary bladder. It is tetrahedral in shape when it is empty. So this is the base and this is the apex. It has an apex which is directed forwards and downwards, and a base of fundus which is directed backwards. Base, this is apex, and this is the base, and neck, which is the lowest and most fixed part of the bladder. And okay, this is the neck, which is the lowest and most fixed part of the bladder. There are three surfaces. This is the superior surface, infero, and the two other right and left inferolateral surface. And four borders, that is two lateral, one anterior and one posterior border. Then a full bladder is almost ovoid in shape, and it has an apex which is directed towards umbilicus, a neck directed downwards. This neck is directed downwards when it is full, and two surfaces, that is the front surface and the posterior surface. So it is tetrahedral when it is empty, and it is ovoid when it is full. Hope you are understanding. And then coming to the last topic, that is the urethra. It is a thin-walled tube that transports urine from bladder out of the body. The sphincters are two muscles control the flow of urine. The internal sphincter, which is involuntary smooth muscle of bladder neck, and external sphincter, that is a voluntary skeletal muscle in the pelvic floor that you control to delay or start urination. So there are two muscles, the external and internal. The internal is involuntary and the external one is voluntary. And anatomical differences in females, urethra is short, approximately 3 to 5 centimeter or 1.5 inches long, and opens into the opens anterior to the vagina. So because of the short length, females are more prone to UTI, that is urinary tract infection. Then coming to the male, the urethra is significantly longer, roughly about 15 to 22 centimeter, that is 7 to 8 inches, passing through the prostate to the meatus. And these are the parts of the male urethra. That is the preprostatic part, prostatic urethra, membranous urethra, and spongy urethra. I think you are well aware of that. I need not explain it more, no? And in the female, it is 4 centimeter long, 6 millimeter in diameter, begins at internal urethral orifice, approximately opposite to the middle of the pubic symphysis, runs anterior-inferiorly behind the pubic symphysis, embedded in the anterior wall of the vagina. And it opens about 2.5 anterior to the opening of the vagina, about 2.5 centimeter behind the glans clitoris. And let us come to the clinical aspects. Urethritis is the inflammation of the urethra, so common due to sexually transmitted infections. Then BPH or hyperplasia in the males. It is benign prostatic hyperplasia. It is quite common. Then coming to the urethral strictures, that is narrowing due to scarring. Scarring means constant abrasions, and rare cause of urethral cancer. So this urethral strictures. And catheterization. Its length is S curve shape male urethral that makes the male urethral catheterization difficult as it is S-shaped. Then congenital anomalies is disorders like hypospadiasis, that is opening underside of the penis, and epispadiasis is the opening on top, and that result from abnormal development. And then this is a normal prostate, and when the prostate enlarges, it constricts the urethra, upper part of the urethra, and finally the sphincter itself, the internal sphincter, and finally leads to difficulty in maturation. And this is a female urethra. It is shorter and it is more prone to infection. And the diagrammatic representation, bladder, urine flows here, and these are the urethral openings. I told you about the trigon of the bladder, and internal sphincter and the external sphincter, and the grades of reflex. This grades of reflex is very important, as I hope all of you are aware of this such a condition, that is vesico-urethral reflex. Vesico means bladder, then ureter. That reflex is, it moves GRD. You have heard about that. Gastroesophageal reflux disease. It regurgitates or moves upwards. So likewise, when the urine moves upwards, that condition is called VUR, that is vesico-urethral reflux. It is a condition that the urine flows upwards, back from the bladder, up into the ureters. Potentially, the kidneys, instead of moving in the normal way, direction out of the body, often due to a faulty bladder ureter valve. When the valve is not functioning properly, the backward flow, when it usual flows from above to below, usually this flows from lower part to the upper part. This backward flow allows bacteria to travel to the kidneys, causing recurrent urinary tract infections and risking kidney scarring and damage. It damages the kidney because the waste products, in spite of going down, it moves upwards. So it is graded from 1 to 5. That is based on how urine backs up and how the ureters and kidney dilate with. Grade 1 being mild, that is, it is confined only to the ureter. Grade 5 being severe, that is severely dilated, tortuous ureter, pelvis, loss of normal shape of kidney. And finally, then these are the diagrammatic representations from grade 1, 2, 3, 4, and 5. Okay. And then coming to, this is a cystourethrogram. And this is a grade 5. Here you are unable to differentiate because urine is flowing upwards in spite of moving downwards. And this condition is called VUR. And please be aware of all the symptoms, all the clinical, not symptoms, all the clinical aspects of each and every organ you study, because you are studying anatomy to apply it in your clinical practice. So what sir said, Rakesh sir said at the beginning is absolutely correct, because anatomy is never a non-clinical subject. So these are the congenital anomalies of the kidney and urinary tract. GKUT, CAKUT, congenital anomalies of the kidneys and urinary tract. This is non-development of the kidney is called agenesis. This is absolutely the congenital, that is developmental anomaly, and this is hypoplasia, that is underdeveloped urinary kidneys, ureters, and urinary bladder. Dysplasia means abnormal development of the kidneys, any of these. And ectopic means it doesn't ascend out, which we already learned. And horseshoe kidney is due to the fusion of the right and left kidney. And then this is UPJO, and this is primary mega ureter, ureter and that duplex collecting system. This is DUR, and this is my bladder extrophy, but the bladder is situated outside. This bladder agenesis, that is maldevelopment of the bladder. Then the posterior urethral valves, the urethral valves are situated posteriorly, and it causes UR. Okay, and this is the intrauterine ultrasound in antenatal mother. And I hope this session was at least a bit informative to you all. And I thank you so much for your patient listening.
Yeah, it was a very nice one, and we have learned a lot, and your expertise and experience has been quite admirable, and we appreciate your efforts and your preachings. Thank you very much.
Thank you so much, sir.
Namrata ji, please carry on forwards.
जी सर, थैंक यू सो मच मैम.
Thank you, ma'am.
Now I would like to request to Dr. Sachin Khedikar sir for closing remarks and conclude the session.
थैंक यू नम्रता जी. सभी को नमस्कार. नए वर्ष का ये सबसे हमारी पहली संभाषा है, तो सर्वप्रथम इस मंच से मैं सभी को नए वर्ष की शुभकामनाएं प्रेषित करता हूँ. और सर्वप्रथम आज की जो वक्ता है डॉक्टर बीना उपेंद्रन जी, उनको मैं अभिनंदन करता हूँ. many congratulations man for delivering a very nice guest lecture to us, our scholars or teachers, and the way of delivering and explanation, you are born teacher.
Thank you so much, sir.
The video बहुत ही अच्छा इसका विषय रहा, जिसमें आपने अप्लाइड एनाटॉमी को भी उतने ही बारीकी से डायग्रामेटिकली प्रेजेंट किया. और थोड़ा सा एक हमारे लिए भी है बीइंग टीचर की, जब भी हम प्रेजेंटेशन करते, चाहे यूजी के लिए भी हो, तो जो डायग्रामेटिक जो प्रेजेंटेशन एनाटॉमी में वो बहुत इम्पोर्टेंट है. जो मुझे लगा तो इजी फॉर अंडरस्टैंडिंग भी बहुत अच्छा हो जाता है स्टूडेंट्स को. तो इट वाज वेरी नाइस प्रेजेंटेशन मैम. सभी ने प्रेजेंटेशन सुनाई है और हमारे कन्वीनर सर ने भी बहुत रिमार्क दे दिए हैं. तो अधिक वक्त नहीं गवाते हुए पुनः सभी आप वक्ता का और सभी का अभिनंदन करता हूँ. धन्यवाद.
कोई क्वेरीज हो तो वो कर सकते हैं. If anybody has any query, whosoever is present, he may raise his queries. These are the normal procedures. Everybody may have some queries in mind.
Sure.
He is welcome. Please raise your hands, and if we can connect to him, we will be happy to have his questions.
विकास गुटके सर ने शुरू में ही हैंड रेज किया था.
जी.
पार्टिसिपेंट को मैंने दिया है.
उनको आप इन्फॉर्म करिए कि वो एक्सेप्ट, उनके पास रिक्वेस्ट गई है और वो ज्वाइन करें. एक बार मैसेज कन्वे करना पड़ेगा. विकास गुटके जी, आपके उनको चली गई है सचिन जी, रिक्वेस्ट भेज दी
है. और हमारे आशुतोष कुमार यादव जी भी जुड़े हैं गोवा से. नमस्ते सर.
सर नमस्कार. सर नमस्कार. उनको भी देखे पर वो
कंट्रीब्यूटर का भेजा है सर रिक्वेस्ट.
पिछली बार भी दिक्कत हुई थी, कुछ इश्यूज आते हैं. देखिए एक बार आशुतोष जी को जरूर जोड़िए. देखिए
कंट्रीब्यूटर का रिक्वेस्ट निधि मैम भी है.
जी. साथ
में आकाशदीप मेश्राम सर है, उनको भी भेजी है. गुप्ता सर भी है हमारे स्पीकर. सर को भेजिए कंट्रीब्यूटर की.
सर एक बार ज्वाइन करें सब, प्लीज, आपसे आग्रह है.
डॉक्टर
सचिन
प्रसन्ना
जी,
जी कुछ कहना चाहते हैं, प्रसन्ना सर कुछ कहना चाहते हैं।
प्रसन्ना सर तो जुड़े ही हैं। प्रसन्ना जी अनम्यूट करें। सचिन जी एक प्रॉब्लम है, इसको कैसे रेक्टिफाई करें? एक बार आप सुरेंद्र जी से चर्चा करना ना
क्या
कि
प्रॉब्लम
ये
है?
हम ये जैसे कई लोग नहीं जुड़ पा रहे हैं। आशुतोष जी भी पिछली बार भी प्रॉब्लम आई थी एक दूसरे लेक्चर में भी।
वो
एक बार
क्या?
उसे डिस्कस करना, मतलब कनेक्ट नहीं हो पा रहे हैं ना जैसे अभी।
नहीं, वो वेटिंग में होते हैं ना। एडमिट
हेलो सर,
करना।
वॉइस डिस्टर्बेंस है मेरा सर।
नहीं, आपने बनाया है लेकिन जैसे आशुतोष जी पिछली बार भी नहीं जुड़ पाए थे, आवाज नहीं आ पा रही थी, ये प्रॉब्लम आ रही है। एक बार
हाँ
आप
सर,
पर्सनली एक बार उनसे डिस्कस करना,
ओके
क्योंकि
ओके ओके सर,
अब
वॉइस डिस्टर्बेंस है मेरा।
यादव, हाँ हाँ ठीक है ठीक है। यादव जी आप, यादव जी ने कुछ नहीं, यादव जी ने मैसेज नहीं है कुछ इनका। पिछली बार भी इनका मैसेज आया था बार बार कि कनेक्ट नहीं हो पा रहे हैं, अनम्यूट नहीं हो पा रहे हैं, तो क्या रीजन
फोन
है? एक
लगा के
बार,
देखिए ना, फोन लगा के देखिए एक बार क्या बोल रहे हैं।
हाँ मैं एक बार लगा रहा हूँ उनको फोन, एक बार आप होल्ड करिए एक बार। वो कहते हैं कि उनका कनेक्ट नहीं हो पा रहा है, क्योंकि वो कहता है यू आर नॉट, आपका अनम्यूट नहीं हो रहा है, ऐसा करके आता है मैसेज लिखा हुआ। पता नहीं क्या रीजन है।
सर हमने
ये आज,
कंट्रीब्यूटर के लिए भेजते तो हो जाता है ना, जैसे आज
हाँ हाँ होना चाहिए लेकिन पता नहीं क्या चक्कर में, एक बार पूछता हूँ उनको।